I'm now going to introduce Robert Smith, who is the CEO of the Colorado Purchasing Alliance, and Claire Brockbank, who is the CEO of Peak Health Alliance. And these are two of the employer alliances that have used some of these reports, so they can talk a little bit about their utility and what this means for the work that they're doing. Bob, I know you have got a few slides, so I think I might hand it over to you first if you want to talk through those slides.
All right, very good. Thanks very much, Kristen. And Emma, I really appreciated what you presented. It's one of the reasons, and I've said this many times, that Colorado is the best positioned state in the country to drive state-based reform, which is where it's going to have to happen. And I think CIVHC, particularly with as a robust database as you have with the all-payer claims database, it benefits us in a number of ways. And we've long considered CIVHC to be a strategic partner, sharing data with our employers, and we've used that in a number of ways. But now we're actually beginning to use CIVHC as a critical resource for the Colorado Purchasing Alliance. And so if you flip to the next slide, and I just have just a couple. So I think I genuinely believe one of the reasons that the Purchaser Business Group on Health out of California, which buys healthcare for about 40 plus jumbo employers across the country, one of the reasons they wanted to pilot this local national alliance with us is because of the robustness of the data that we have. So this is who we're working with. We represent, you can see the employers and the Colorado-based employers, but it's difficult to move the needle with just Colorado-based employers, and many of our employers are national employers. So you can see that by being joined by the Purchaser Business Group on Health, we roughly double the size of the purchasing. So if you flip to the next one here, I'll show you how we use these data. So this is basically a summary of the sources and uses of data. I'd point out the quote by Deming. I think it's an important point. We really basically have three strategies: identify and select, collectively identify and select high-performing, high-value providers, and that's key. That's what we're doing with PBGH. We're also engaging physician-directed entities both at the statewide level, Colorado Medical Society, and others, because we want to put physicians in control. And we've committed to physicians that the data that we look at, we will share with them to gain their trust. And then the third is to engage and empower employees. The RAND relationship, which Dave touched on, is absolutely critical to this because we do have one of the most robust all-payer claims databases in the country. By having that collaborative relationship, and it's always gone very smoothly, we can use RAND data as well as embedded healthcare Blue Book data to drive all three of those strategies. And that's why the APCD is so central. We'll also use it, as you can see, to run reports on low value care. That's been very helpful to us. The outpatient pricing analysis has been very helpful to us, and then a number of employer supports. We use some other data from MedPAC and Healthcare Regional Information System to do benchmarking, but that gives you a sense of how central the all-payer claims database is to our efforts.
Great, thank you, Bob. I'm going to pause the share real quick and ask Claire Brockbank if she could give a few words about the work that you're doing with the Peak Health Alliance.
Thank you, Kristen. And thank you for having me. And I do want to stress that Emma ended her presentation with an offer to assist. And I will tell you from personal experience that the offer is very real and genuine. The team at CIVHC have been amazing in terms of, helping wrap their brain around the issues that we deal with. So I would really encourage you to call Dave, to call Emma, to reach out, because they really are fantastic. It's a resource that we are extraordinarily lucky to have, in addition to the data, of course. But I think, as Bob said earlier, you want data to turn into action, and it takes the guidance sometimes of some good data navigators to help you turn it into action. So I thank you all for that work and encourage people to take advantage of that. So the team asked me to tell you a little bit about how Peak uses data, but I thought it might be helpful to just give a very brief description of what Peak Health Alliance is. and we are Colorado's only licensed and fully operational healthcare purchasing cooperative. That gives us the ability to negotiate directly with both providers and carriers to lower health insurance costs on behalf of our members. We pool large self-funded employers, small employers, and individuals to speak with one voice. So we currently operate in 7 counties. We'll add an additional county in 2022. And between 2020 and 2021, we estimate we have saved about $9 million in lower insurance premium costs directly for our communities. And those are, that is separate from reinsurance. So we are up and operational and walking the talk with all of the challenges that goes with that. So how do we use the data? I would say it's our starting point. So in new communities, so if we started in Summit, then we expanded to 6 communities, we've expanded to another community. We use the APCD data to help analyze what's actually driving the cost of care in our communities. And that can be different in a rural community served by a critical access hospital than in Denver, or a mountain resort community served by a large health system. So that becomes really an important part of our analysis. That data helps us level the playing field when we talk with providers. And I will say, you've heard this morning, or this afternoon, I guess, that there is the publicly available reports, and our first stop in the process is the publicly available reference-based pricing report. As Bob talked about, that's done in combination with the RAND data. The second piece, though, is the custom data analysis, and we have in all of our counties taken advantage of the opportunity to get custom data to dive a little bit deeper into understanding in greater detail where care is being provided, what might be driving the higher prices, what are some opportunities, et cetera. So that data really levels the playing field for us. When you sit down with a hospital and they say, no, our costs are actually very, very reasonable, and you're able to say, well, we're not sure that 850% of Medicare is reasonable, it changes the dynamic of the conversation. It allows us to find a constructive middle ground, and it allows us to have a baseline. So when we know what the percent of Medicare is, as an example, in Summit County or in La Plata County, Durango, and then we get a fee schedule from providers, we are able to then run that through with our actuary and know how much movement we've had from the baseline percent of Medicare. So hopefully that makes sense to the folks in your audience. It gives you a sense of change, and you can validate. And healthcare is a black box. Anytime you can use data to validate what you're doing, you have more odds of success. I think that's why our negotiated fee schedules have resulted in such dramatically lower premiums, because we were able to make sure that those fee schedules were real, right? I think the second point I'd like to make is that although we often look to immediately reduce the cost of insurance to our members because that's such a pain point, but we know that addressing those other cost drivers is equally important in the long run. And that's where the employer reports that the team described, that Emma just finished describing, are so important. Those help us think about what are our opportunities to identify unnecessary care. Do we have a generic versus name brand prescribing issue? Are we seeing underutilization? For us, then we have to take that and work with our 2 very distinct members. I see a question that just came up, and you must have been reading my mind. We serve self-funded members, insured group members, and individuals, folks on the individual market. So that is very unique nationally. So when we use that data, our self-funded employers use it similarly to how Bob's employers might think about using it. They have to help them think about benefit design. We help them think about other ways to structure the way they are choosing to offer services to their employees. For our group and our individual market, we have to work with the insurance carriers that we've partnered with. And part of the condition of partnering with Peak is a willingness to sit down with that data and identify opportunities. So as an example, we knew that mental health was a big issue We knew from some of the CIVHC data what a high percentage of our ER care had a mental health component to it. And so we used that data when we negotiated with and selected our first carrier to say, we want to change the benefit design for mental health. We want to remove the deductibles for mental health. We want to remove the copays for mental health. So in our counties right now, our carrier on the insured side, not the self-funded side, is required to pay, to provide outpatient therapy with no copay and no deductible. That was driven by data. Now, we have not been able to test the impact of that in part because of COVID, but we will be knocking on your doors as our, as the data comes through. So those are a few snapshots of how we use the data. I think what's really important though, if we have people on the webinar who are thinking about doing this, is to remember that as Bob, I think of it as Bob's outpatient procedure report. I know it's a case study that you guys featured, but the APCD data lets you get your arms around what the opportunity is. It doesn't tell you how to take advantage of it. It doesn't tell you how to realize the savings. And so that's where it's really important to know that the work, that it's hard work to get to the report that helps you diagnose the savings, but you've got a lot more work to then say, how do we actually realize it? And then how do we measure it on the back end? And we're not at that measuring on the back end yet. We've been operational for 2 or 3 years, but we're not there yet. But I anticipate a pretty robust partnership with CIVHC as we do get there. I'll pause there. That was a lot that I just threw out.